All right, welcome everybody. Happy to have you join this week's office hours session. Happy this week to be joined by not one, but two of our coding experts here at Infinix. We've got Bo Bowman, our VP of Strategic Accounts, and Kathryn Walter, who is one of our coding experts. This week, we're going to focus on coding challenges, including denials, and how to avoid them, and also trying to identify when is it time to ask for help. So welcome, Bo, welcome, Kathryn. Happy to have you both here.
Thank
you. Yeah, let's jump right in. What coding denial trends are you seeing right now from payers?
I'll start. So as we were kind of discussing earlier today, and really kind of looking around the landscape of all specialties, commonly we see wrong modifiers. There's a whole, kind of set of portfolio knowledge that a provider and their staff may need to ensure they're using the correct modifier depending on, the situation, again, depending on the specialty. Lack of medical necessity, not properly documented. That's a pretty common coding denial that we see and are able to remedy in our billing process. Requests for medical records, oftentimes on very busy or complex procedures, all of the record has to be there to support for the payer and has to align with the codes that have been used. Another one that we see that's real trendy, at least for the past, 2 or 3 years here, is the MCCI edits. If there are other coders or technical billing folks that are listening today, they've had to deal with this, and this is the whole bundled versus unbundled delineation. So codes that are either are bundled or have been bundled, and then based on the regular and new CMS regs should be unbundled, and the whole education that has to go on with that, both in a particular doctor's office or provider's office, is complicated and hard to get the language all the way through. But those are some big ones that we see right now.
Great, thanks. Kathryn, anything you want to add to that?
Thank you. Authorizations. This is a big one where authorizations do not meet the CPT codes that were submitted to gather an authorization. And it's a possibility that your surgical team who are submitting these auths require a little bit more education in coding. I've noticed that, let's say in particular with interventional, with the cardiology, they'll choose one code, but there may be 4 or 5 codes that go with that. And then we're not quite sure whether or not you're actually going into the family that is being authorized. And therefore, if you're just using a selective catheter code instead of a intervention, then that's going to deny the whole claim. And it's very, very difficult to get a retro auth. You have about a 24 to 36 hour window to get a retro auth if you come back from the operating room, procedure room, and tell your staff that you did something a little bit different, or you changed it from an open procedure, or halfway through you had to put it back to an open procedure. What you finished off with is what we're going to code. You cannot put these two codes together and expect to get reimbursed. Another is the medical necessity. If we're not looking at our LCDs, NCDs, and clinical policy bulletins, there's specific diagnosis codes that meet the criteria for CPT. And if your diagnosis code is not on that list of approved conditions, your claim will deny even if you did receive an authorization, because authorizations are for CPT, not for condition. They're two of the biggest areas of denials at the moment.
Hey, Kathryn, do you want to hit on a little bit more detail with bundling and unbundling and what reference you may lead a provider or practice to learn more?
So that would be education, education, education. And as I mentioned, and I've always gone by this, you get paid for the end of the road. You do not get paid for the journey. So for instance, if there is a catheter, even if it's a selective catheter, if that's included within the procedure for an intervention, that gets bundled in. You will not get reimbursed for it separately. So you're only going to get paid for that final code. It's very wrong to unbundle your coding. You're going to have a red flag there, and the more that a payer is going to see that you're unbundling, it's going to open up for an audit. So we do need to follow the guidelines of coding, NCCI edits, first and second column rules, etc. And that's where it comes in that we do need to have certified coders, and those coders that are actually familiar with your particular specialty.
It's a really good point, Kathryn. What are we seeing? So we've heard a lot in the news, heard everywhere about the staffing challenges that healthcare has been dealing with for the last couple of years. Bo and Kathryn, can you touch on how that's impacting coding and what you're seeing in the market in terms of coder staffing shortages?
I'll touch on some of the administrative burden, and then I'll bet Kathryn can let us understand it from the actual coder's view. You know, from the practice or from the administrative side, you know, technically, you know, having a shortage of properly trained coding staff really affects charge lag. So in whatever medical arena you are, you're watching your charge lag. You're watching how quick it takes from the moment the services are rendered to actually getting the charges in your particular system. And so you're not having either the right or the quantitative amount of, again, qualified billers and coders really can delay that, thus delaying, you know, how quickly you get your claims through to the clearinghouse and then getting paid and starting the parts of your payment posting to help your cash cycle. So administratively, you know, it can be a real burden on the revenue cycle for a given practice. I don't, Kathryn, what are your thoughts on staffing shortages?
We've just come through 2 years of pandemic, and a lot of our staff have stayed away from healthcare, and we had to try and get them back into the office. One of the important things, we are a customer service based business, and it is a business. Do we cut corners, or do we incentivize our staff with more on the front end in their benefits and also their paycheck? Do we not pull them away? One of the biggest complaints that coders have is that if our front desk staff are out, then the coders will get pulled to the front of the office. We're not paying our coders more money to sit up the front desk and answer phones. And so we feel that we need to pull our coders away. We need to be able to ensure that they are just coding. And with that coding, we need to have continuous education over the next, well, it's been 2 years, and we've got another 2 years of really coding is being pulled up by the boots. 1995, 1997 guidelines have gone out of the window. We've got 2021, 22, and 23 guidelines coming in, and therefore we've got to keep up with education. We can't pull our coders into 3 or 4 different areas. If we do allow them to stay at home, where is the education for them? We need to be able to offer that in-house, and also give them the correct areas and places to go to be able to maintain the education that is needed for our coding team. Also, if you only have one coder in the office, they haven't got anybody else to talk to about this. And so with our coders, there is a team, and it's really important that we can talk to each other to get those difficult questions, procedures out of the way. That will certainly help to getting those claims out the door timely, rather than hesitating about just opening up a CPT code book and placing a pin in the closest one. So it's a team effort, I believe. We need to have that education team.
Those are all really good points, Kathryn. I think I would also just ask the question, have we really recovered from ICD-10 staffing shortages? Like, been in healthcare a long time, and these coding staffing shortages have just been an issue for a lot of years. And now on top of that, we've got the pandemic. I think we're just seeing unprecedented shortages. I don't know if you'd agree, Kathryn or Bo.
I would say we're hopefully through the worst, and maybe a little light at the end of the tunnel. Where our offices are in multiple places, we're hiring right now, which is great. We're in a growth mode, and so we've had positions posted, and I don't know if we've been able to say easily fill those positions, but there's no doubt that again we are changing, I would say, the way we position the subscribable job for a certified professional coder or an apprentice or a billing specialist who's interested in becoming a coder. I think, me personally, and kind of our management style that we have is we try and foster anybody, whether they're a client of ours or an internal employee, that if this is a path they want to go down in a career they want to pursue, we highly recommend they engage with AAPC or other professional organizations and, maintain their continuing education. But, as for a shortage, we've seen applicants, and I know other practices have had to either maintain and retain or go out and find new. And, there's accommodations, that can be made. I think a work from home hybrid schedule is an opportunity. I think every employer may do that a little bit differently, but I definitely think that's a possibility depending on what you're doing. There is some educational differences between a true inpatient coder that works on the throughput of claims for hospitals and maybe surgery centers versus the throughput review, audit, and analysis of claims for, say, a medium to large medical practice. And some of that is the personality of that particular candidate. There are some candidates that love the inpatient side of the coding world, and some coders that like outpatient. So, again, I think you're looking for people that are the best fit for what you need done, and I'd like to say we're on the upslope there.
Awesome. I think that's a really interesting idea. Invest in, for those practices and providers that are seeing staffing shortages, invest in your people. Get them into an AAPC program or something that, help them advance their career.
Agreed.
It's an interesting idea. I think we talked about, the shortage of coders in the market and kind of what we're seeing. Let's jump to, how do you know when it's time to ask for outside support?
I'm going to just say a real quick one and then turn it over to Kathryn. I've been on both sides, medical practice, oversight, and then also been on billing teams. And, from my view, the one that sticks out is when you start getting audit requests. Audit requests are pretty interesting because you're taking an internal look at your own performance. And so when it's time to audit, I would say that's a great time to look outwards. Kathryn, what has been the experience in your career?
So I started out in the year 2000, looking at self-pay and wondering why self-pay wasn't getting paid, and it was for an anesthesia company in Orlando. It really opened my eyes, and it also made me listen. And that's the biggest thing that I believe our staff need, is to be able to listen with all of their ears, not just tunnel vision. You've really got to understand the complexity of finding out why a claim isn't reimbursed. And I think that I'm going to go on with what Bo had said. Staff in the office, if they're given an opportunity to look and see from the back end of a claim, and then to come to the front end of a claim and see, well, how was it actually coded? That's how I was taught, and I found that the best way. It's a lot of detective work. You really have to understand the complexities of everything. I get so excited when I'm talking about coding, because it's a puzzle that you have to open. But one of the other items I firmly believe is education of our providers. Face-to-face education, auditing. Yes, providers don't like to hear the word audit, but we all have to learn. And as mentioned, with one set of codes, the difference between saying with or to or through can be the difference between 5 work RVUs and 25 work RVUs. Very different, especially when you're thinking that you're saying the right thing, but the code book says not. So education of our providers is really important. And moving down into the practice as well, and everyone gets the same message rather than a little bit of one and a little bit of another. We all need to be on the same page, being educated at the same time. I think that that's one of the most important areas.
What are some of the benefits in terms of leveraging a third-party coding provider, or I think partner might be a better term for that?
Absolutely. Again, you want, if you're running a large practice or a small practice, whether it's family owned or, has a corporate interest or whatever it is, again, kind of that bias, neutral party to help us, guide us, educate us. I would say kind of 3 things that stick out to me is expertise. When you bring a third party in, and that's all they do, there should be a high level of expertise you can lean on and trust. The staffing consistency, again, if that's all we do, right? In a big medical practice, there's all types of staff that have all types of different responsibilities, but a third party coding provider is going to be doing the same thing every day and be up to date on governmental changes or standards. And then the other thing I thought of, especially post-pandemic, is kind of help when the workload spikes. So we continue to live in a seasonal world when it comes to healthcare volumes. The pandemic has altered that in some ways, and in some ways we're recovering from it. But we've definitely seen requests from various clients and providers that, hey, workload's gone through the roof and we have a few out, and we need help bringing the amount back down. So I think those are good opportunities to look at bringing on a coding provider. I don't know, Kathryn may want to speak to, she's been a third party for a while and may want to speak to the expertise function. What do you think, Kathryn?
I always look back to when we started taking our coders out of the office, and I likened it to the security blanket of the provider being removed from the office, where you could just walk down the corridor into the coding room and speak to your coder. That definitely is one of the bad things, I would say, if you want to call it that, the negative side. However, one of the positive sides is that if your coder goes on holiday, heaven forbid they're on FMLA, and your coding is backing up, there is no one else to do that. When you are with a company like Infinix that has multiple coders, you may have the same coder who starts to understand your wording, but we also have another if they go on vacation. So we have a team. They are definitely specialist oriented, and we don't try and put a cardiology coder with somebody in neuro or in OB-GYN. We try and link, and we've been very successful about this, linking coders to the specialties that they are more familiar with and have expertise with. As mentioned, you may not be able to talk to your coder per se, but there should be a manager who should be able to talk to them. It allows you to have freedom and understand that your coding is being held to the highest.
Makes sense. Any risks that you would throw out there for providers that they should watch out for in terms of a coding partner?
You know, again, I think you should vet a few. I think you should ask if you're going to go into a contractual arrangement, whether formal or informal. I think you should ask if the coders that are going to be working on your clinical provision are certified. If they are certified, are they certified in a particular specialty? You know, you can even ask for their latest educational hours and certifications. So I think you want to make sure that, you know, you're partnering with the right group. We surely do that at Infinix and Enhanced Revenue Solutions. We make sure everybody has all their education hours and they're up to date, and then we help and subsidize some of that. So that's important. I think those are some of the technical things you need to look at. I think some of the qualitative things are just, it can be humbling. You know, when you bring in the experts, you have to be ready to hear, you know, what you're doing well, what you're doing not so well, and where there's opportunity. And as long as folks keep an open mind, I think that can go very well. Would you agree, Kathryn?
I will agree. I'm one of the sticklers, and I've had to, you know, we all say humans don't like change. And I'm one of those that basically, unless I think about it and decide to change, I don't like somebody putting it in front of me that I've got to change. Now, this is one of those areas that I really had to think about this. And I always thought that we shouldn't go outside of the company. But these last 2 years have shown that we do have to go outside of the company. We have to open up our thought processes, that we do need that assistance. There's help that is out there that is really needed. So that's been a big change for me, and I've now welcomed it. It's been eye-opening. Bo did say you do have to talk to anyone that you are, even if you go outside of Infinix. I hope you don't, but do go with other companies. It might just be the case of how they shook your hand and smiled at you. Never mind what is behind the scenes. You really have to understand that you've got to be comfortable, because you are trusting them. You have to trust them.
What about the impact that a coding partner can have on reimbursement? And I'll just follow that up with, you know, any suggestions that you all have in terms of how to vet a partner. Bo, you touched on that a little bit already, but any other advice you would have for folks would be awesome.
I might turn that one over to Kathryn. So Kathryn, as you've come across various practices, you know, we always want to see reimbursement improve, but you know, how would you say when a practice is looking at their reimbursement, well, the immediate impact a coder can make? What do you think that's like?
It's correct coding. It's following the guidelines. You cannot simply get away from the correct guidelines, because and here's where we're going to say this, you may get the money, but Medicare, CMS can go back 7 years. And if they look at an audit, a retrospective audit, and find something incorrect, they can go back those 7 years. Well, you got paid for a really big procedure last week, and you've already paid the electricity bill and the staff. But now you've got to give it back 7 years later, and that might be with interest. So we endeavor as coders to ensure that your claim will go out clean the first time around. And I touched upon the fact that there's coding changes that have been occurring the last 2 years, and moving forward into next year, they're still changing with the inpatient coding. E&Ms, they are going to pro fee rather than fee for service. And some of your contracts are heavily designed that family practice, internal medicine is now in the key. They've been in the background for a little while, but now family practice, internal medicine, and E&M coding has come forward. Your diagnosis codes have got to be spot on and higher specificity. And a coder will ask, they can't tell you, but they can recommend, your documentation supports this code. Do you agree with it? And by adding these codes, it's going to help and assist with your payer contracts over the next few years. It's already started, but it could really ramp up within the next 2 or 3 years. You've got your HCC and risk adjustment factor coding. It is really important that we start this off right and make sure that you are documenting in detail. That's one of my little joys at the moment.
As for Kate, vetting a coding partner, I would really search to see if they're up on the latest rule changes that, either CMS or, again, Kathryn mentioned 2023 guidelines approaching, but on the inpatient side, there's different rules now on how and when we can code and charge for a consult. That's new, relatively new. In the past, whenever a inpatient physician, maybe an internist or a specialist like a cardiologist could be rounding, there's rules now on how often you can consult and provide those services, and being able to stay up on something like that. Same day billing is a problem, and a good coding partner should know how depending on how much clinical services were rendered to a patient on a given day, that you cannot potentially bill in a duplicative fashion. And so, understanding that your coding partner knows, that technical piece, and then at the same time, has the educational hand to relay that information to the practice principals. It's probably the most important thing you're looking for when vetting a group.
It's great information. Those are all the questions I've got for you. One call to action or last piece of advice that you would give providers?
Go for it, Kathryn.
Okay, because I have been the coder, because I am an auditor, providers, physicians are standalone. You do not bill as with a hospital where it is from admit to discharge. Our providers are paid per visit. Your documentation needs to stand on its own. If you want some of your documentation that is supported in another document to be included, you have to put a link or a bridge in your documentation. Otherwise, you're not going to get paid in the 15 or 20 days. And you may get it denied for medical necessity. It is really important that your documentation stands on its own. It's not supported by any other documents. That is a big bugbear of mine when I have to go to a provider and state that you didn't put medical necessity in your operative report. Well, it's there in my H&P, yes, but you did not link it. And it might be an eye roll and everybody goes, duh, but unfortunately, that is one of the simplest ways that you can ensure that your claim will get reimbursed in good time.
Really, really good advice, Kathryn. Thank you for that. Thank you, Kathryn. Thank you, Bo. Lots of really, really good actionable information for providers. So have a great evening, everyone, and we look forward to seeing you back here next week.
Thank you.
All right. Thanks, everybody.